Hello, everyone. This is Dr. Siddhaya Subramania. I'm an upper GI and general surgeon. Today, I'm going to talk about sleeve gastrectomy, one of the most common bariatric procedures that is performed worldwide. So what is sleeve gastrectomy? It is one of the most common and most popular bariatric procedures that is performed all over the world. It is normally performed in a minimally invasive fashion or a keyhole fashion, either laparoscopic or in some of the countries, robotic. It is not reversible. Once a portion of the stomach is cut out, we cannot actually rejoin it. It is effective in majority of the cases, up to 85% of the cases. The biggest advantage is it allows natural eating habits. And with major complications being in the range of 1 to 5%, most of that is leak. It is one of the safest bariatric procedures out there. It has fewer problems, and if need be, it can be converted to other bypasses in the future without compromising the anatomy of the bowel. So it was introduced in late 1990s. At that point of time, it was done in an open fashion. The first keyhole or laparoscopic sleeve gastrectomy was performed in 2000, and since then it has gained huge popularity. So who actually qualifies for sleeve gastrectomy? It depends on a number of factors, and that needs to be decided as a discussion between yourself as well as your specialist. It majorly depends on your BMI. With the current international guidelines, anybody over the BMI of 30 or body mass index of 30 qualifies for a bariatric surgery. It's ideally suited for class 1 and class 2 obesity, although we do it sometimes in class 3 obesity as part of other procedure or as a first stage leading on to more complex bypasses. It also depends on presence or absence of other medical issues such as diabetes, high blood pressure, and sleep apnea, and as well as presence or absence of reflux. So how actually it works? So sleeve gastrectomy involves taking out about 75 to 80% of your stomach, thereby reducing the capacity of the stomach. So the reduced capacity reduces the appetite as such, forcing you to eat less and less. Now, having taken out majority of the stomach, where a hormone called ghrelin is produced, we actually make sure that the ghrelin production is reduced. Ghrelin is an appetite stimulant, so less of ghrelin means better satiety or early satiety. The other mechanism with which sleeve gastrectomy induces weight loss is controlling two other hormones, cholecystokinin and pancreatic polypeptide, that are produced in the small bowel. They are normally appetite suppressants. By increasing these hormones, which is the effect of sleeve gastrectomy, the appetite is furthermore decreased. So how it is done? It is mainly done in a keyhole fashion with either 4 or 5 laparoscopic or robotic ports. The stomach is converted into a tube by firing of multiple staples and removal of about 75 to 80% of the stomach on the left-hand side, thereby converting the whole stomach into a tube, thereby reducing the volume, and the volume reduces appetite and brings about early satiety. And as I said before, it has a normal passage of food without disturbing the anatomy for future operations or majorly in any sense. How does it compare to other bariatric procedures? Now, one of the most common bariatric procedures out there, apart from sleeve, is a Roux-en-Y bypass or a Roux-en-Y gastric bypass. So sleeve achieves about 60% of the excess weight loss compared to 70% excess weight loss of the bypass. So what is excess weight loss? Considering 25 BMI as the ideal BMI, any excess weight beyond that is called excess weight. And we tend to achieve about 60 to 70% of excess weight loss by doing sleeve gastrectomy. The weight loss is consistent. The success rates are about 80%. The effects on diabetes is significant, especially if the diabetes is mild or severe. Sleeve gastrectomy is probably one of the best choices. It might not be the case if the diabetes is moderately controlled or moderately severe, in which case the bypass is probably a better option. The complications rates are much smaller, in the range of 1 to 5%. The nutritional deficiencies or nutritional effects are much lower, and eating is not usually a problem. Now, in terms of other side effects, there are some GI side effects such as diarrhea and constipation, which is also associated with other bariatric surgeries. Dumping is not noticed in sleeve generally, but on the other hand, the complication that we need to keep an eye on, or a side effect, is the reflux. The sleeve being a tube increases the pressure in the tube that only forces the acid to go up. Now, not everybody gets affected by it, but it needs to be kept an eye on. Now, what happens after the sleeve gastrectomy? It's ideal and it's preferable and recommended that you follow up with your surgeon as well as the dietitian for at least the first 2 to 3 years, ideally lifelong. First 2 to 3 years is a crucial period where the weight loss is maximum, but at the same time, the weight regain or plateauing of the weight is also seen in the first 2 years. And this is where additional intervention or treatment by a surgeon or dietitian is vital. Endoscopic surveillance or having gastroscopy regularly is something that is becoming more popular. The reason behind this is, as I have said before, sleeve gastrectomy converts the stomach into a tube and potentially increases the reflux. Now, the reflux affects the quality of life, but also the amount or the degree of reflux can also give rise to something called Barrett's esophagus. Barrett's esophagus may or may not be symptomatic, and it's a condition that can give rise to cancers of the food pipe or the esophagus. So ideally, long-term follow-up by both your surgeon's dietitian with endoscopic surveillance is preferable. Now, long-term outcomes are achieved by following certain rules. And surgery helps with the physiology of the appetite, but it does not fix poor nutritional choices or bad eating behaviors, which is what we need to fix as well. If need be, a psychologist will be included in the multidisciplinary team to help the patients along with the surgeons and the dietitians. Lifestyle and eating habits must change for a long-term outcome, especially in the first 2 years, because, as I said before, the weight loss is maximum in the first 2 years, as well as weight regain or plateauing is also seen in around second and third year at the same time. So finally, surgery plus lifestyle together is what gives us success as well as sustained success, but a sustained success and long-term outcome. Thank you.